Andrea Baer, and I am the Director of Patient Advocacy and Program Management for Mended Hearts. Today, we are kicking off our webinar series on reducing your risk of heart disease. And our first topic is controlling cholesterol and diet modifications. Joining me today, first I will talk about the mission of Mended Hearts, and that is to inspire the hope and improve the quality of life of heart patients and their families through ongoing peer-to-peer support, education, and advocacy. We have 285 chapters across the country, serving over 460 hospitals. Joining us is the American Society for Preventive Cardiology. The American Society for Preventive Cardiology's mission is to promote the prevention of cardiovascular disease, advocate for the preservation of cardiovascular health, and disseminate high-quality evidence-based information through the education of healthcare clinicians and their patients. Joining me today is Dr. Amit Khera, a professor of medicine at the University of Texas Southwestern Medical School in Dallas, Texas, and he is also the president of the American Society for Preventive Cardiology. I also have with me Ron Manriquez, who is the Western Regional Director and the president-elect of Mended Hearts, and have Angela, his wife. Angela Manriquez is the Western Assistant Regional Director of Mended Hearts. Everyone who is listening to us, I would like to let you know that you are in listen-only mode. There will be a time to ask questions at the end of the presentations. If you would like to type your question in the chat box, you can do that at any time. And at the end, I will then read the questions to the panel and they can ask them. Or if you would prefer, you can raise your hand, and at the end of the broadcast, I will unmute you so that you can ask your question personally. For now, I would like to turn the presentation over to Dr. Khera, and he will walk us through some of the steps on controlling our cholesterol and diet modifications. Dr. Khera?
Okay, well, thanks so much, Andrea. I really appreciate the opportunity to speak with you all today. I am president of the American Society of Preventive Cardiology, and our organization certainly overlaps significantly and squarely with what your organization tries to achieve. And so we really appreciate this partnership on this series. I'll also say I had the privilege of speaking at a Mended Heart conference several years ago and found it to be a really valuable experience. So I appreciate the opportunity to speak with you all again today. Well, I'm going to talk to you a little bit about cholesterol control and dietary modification. And I'm going to thank Andrea in advance because she's going to help advance the slides. So we'll take the next slide, please. Okay, so, first is just setting the stage to remind us of how central cholesterol is in the role for atherosclerosis. So today, most of my comments are going to be focused on what I call secondary prevention, because I know your organization mainly focuses on people living with heart disease. So when we think about atherosclerosis, the buildup in our arteries, which is the precursor to heart attacks and strokes and issues like that, we've known now since the 1800s that cholesterol is at the scene of the crime. And here is a picture. On the left, it says lumen. That's a drawn picture. On the right is actually a histologic specimen, meaning sort of from an autopsy, where you can see where cholesterol lives. So the lumen is where the blood flows, and then that yellow crescent looks like the moon is essentially what we call the lipid core, and that is full of cholesterol crystals and also has some inflammatory cells. But cholesterol is central in atherosclerosis, the buildup in our arteries. We've known that for a couple hundred years now, and I think what we've learned more recently is about treating cholesterol to lower heart disease and how central a role it has. Next slide, please. So just to remind us, so we're all in the same vocabulary a little bit, because we're going to be talking about cholesterol levels, and I'll talk about what levels I'm referring to. And I should also say, at the end, I really hope there's lots of questions. That's the best part of these sessions, so please do type in your questions and be ready for them. But we really focus on our LDL cholesterol. That's our bad cholesterol, and this slide was actually from 2001, and at that time we used to say under 100 was optimal. But we're learning that actually, and I'll show you this at my last slide actually, that really under 70 or maybe even lower is now what we're considering optimal for the LDL or the bad cholesterol. Above, certainly for someone with heart attacks or strokes, that's where we want it to be. Total cholesterol, we focus on a little bit, but not as much anymore, and I'll tell you why in a second. But the good cholesterol is the HDL cholesterol. Less than 40 is considered low, and a woman less than 50 is actually a little low, and above 60 is very good and high. The reason we don't focus on total as much as total is actually the LDL, the bad, plus the HDL good. So I've had referrals of patients with very high good cholesterol that get referred for high total cholesterol, but they actually don't have a problem in one way as we think about the bad cholesterol, the LDL. Next slide. So this is a tricky question. What is a healthy diet? And I spend a lot of my time in my clinic talking to patients about this. Every one of our new patients sees our nutritionist for free because we believe so much in the importance of diet in preventive health. But to answer this question, I'm going to go to the next slide, please. When I meet with a patient, the first thing I say is, before we talk about diet, tell me what is your goal? Because when you read on the internet, there's so much information, and it's overwhelming and confusing, and I certainly understand that and hope to clarify a little bit of that. But as a heart doctor, when people are meeting me, when we're talking about diet for heart disease prevention. If your goal is bone health or weight loss or joint health, that might be a different diet. And by the way, those aren't the same thing. We'll talk about this in a little bit, but you can lose a lot of weight and still worsen your heart disease risks at the same time. Certain flavors of the keto diet can do that, not all. So those aren't the same thing. Everything on the slide is not the same. A heart disease prevention diet is what I'll focus on. Next slide. So when we look at your cholesterol panels, we all get a cholesterol panel from our doctors as a total cholesterol. We talked about LDL, HDL, the good cholesterol. There's also triglycerides, the TG here, which is the fats in your blood. And if you're trying to manipulate those with your diet, there's different things you're going to focus on. And if your focus is to lower your LDL, the bad cholesterol, you really need to focus on saturated fat. And I'll talk about that in just a little bit. You also want to reduce cholesterol in your diet. And by the way, there's things you can eat to help lower your cholesterol. That's soluble fiber. We always talk about eating oats and bran and things like that. And then there are certain things you can buy over the counter called plant sterols. But those dietary changes are if you're trying to lower your LDL or bad cholesterol. If you're trying to lower the triglycerides, some people have high triglycerides, particularly if they have diabetes or prediabetes. Losing weight helps a lot there, reducing simple carbohydrates and increasing exercise. You notice at the top, I didn't put exercise on the top, and a lot of people misconstrue this. Exercise helps a little bit with your LDL or bad cholesterol, but it really doesn't help that much. It's predominantly diet and genetics. Next slide. So let's talk a little bit about dietary fats and saturated fat. And again, many people are probably very familiar with this, but saturated fats are whole cheese, whole dairy, butter, animal meats, and desserts, fried food. Those are all our saturated fat, and that will certainly raise your cholesterol, which we'll talk about in a second. For unsaturated fat come in monounsaturated and polyunsaturated. Monounsaturated is your avocados, your olive oil, your walnuts, and then omega-3, which is your fish or flaxseed, and then omega-6, which is a lot of your plant-based fats. So the ones on the right do not raise your bad cholesterol. So those are okay in terms of your cholesterol. The ones on the left certainly will, and I'll show you that in the next slide, please. So here's the study just to show you. I guess those dots got blown up a little bit, but this is a study just to show you. A lot of people, ask this, does the saturated fat really affect your cholesterol? It definitely does. Here's an example of that. This was a study done at my institution by one of my colleagues, Dr. Grundy, who's the chair of the new cholesterol guidelines. And ironically, this is about 30 years ago before his most recent guidelines. But here they took 22 patients, and let's focus on the right where it says LDL cholesterol. At the bottom, it says high poly. So first they put them on high polyunsaturated fat, safflower oil, and saw what their LDL cholesterol was. And on average, it was about 140. Still a little high, but that's where it was. Then they took the same people and they switched them over to saturated fat, palm oil or lard, and their cholesterol went up the bad cholesterol went up by 42 milligrams per deciliter, 42 points, so now is averaging above 180. So, and if you look, almost every one of those arrows was upwards or trends was upwards. So there's no question that saturated fat will increase your cholesterol. So if you're trying to lower your cholesterol, you have to reduce saturated fat in your diet. Next slide. Now, saturated fat, the problem is you might, I know your group is very astute and follows the literature and all the things out there. And the problem has been dietary whack-a-mole, and that's what I call it, because what we did historically from the 70s through the 2000s, we said, don't eat a lot of saturated fat, and everybody stopped eating a lot of fats. But what did they do? We ate a lot more simple carbs. So we ate whole fruit, these sugar-free sweetened beverages, fructose corn syrup, all the things, white rice, white bread, all the things that we do. And that's not necessarily good either. And let me show you what we're learning, which is about, it's not just avoiding saturated fat, but what you replace it with. Next slide. So this is a study, a little bit busy, but I'll walk you through it. This is from the Nurses and Health Professionals study that took 84,000 people. And they said what it is that, if all these people, when they reduce their saturated fat, they ask what did they replace it with? Let's walk it through. Anything on the left of the line, the green, the yellow, the blue, that means benefit. Anything on the right, the red is bad. So if you cut out your saturated fat and instead consumed trans fat, that was bad. If you go down the fourth one, the other red, and I'm sorry that it didn't transfer right when I sent the slides in, but it says refined sugars, starches. So if you stopped eating saturated fat but started eating white bread, white rice, you were no better off. It did not help you. So this is some of that literature where reducing saturated fat didn't help. But look at the other ones. If you stopped eating saturated fat but instead ate monounsaturated fats like olive oil or polyunsaturated fats, or used whole grains, you actually did see a reduction in heart attacks and heart attack risk. So it's not cutting out saturated fat, it's also what you replace it with. Next slide. So the world has evolved rather than spotlighting one macronutrient, just being saturated fat's the only bad guy, but thinking about what patterns of food we're eating. And that one on the right certainly looks like what we're about to talk about, a Mediterranean pattern, really focusing on these patterns. Next slide. So to remind us a little bit about what a Mediterranean pattern looks like on the right, that's a lot more whole grains, different types of grains that people are eating, a lot more fruits and vegetables, a lot more legumes, olive oil, a lot less red meat, a lot less dairy, frankly, in terms of Mediterranean diet, fewer sweets and eggs, but a lot more fish and good oils. We see olive oil there. Now, we've known that for a while, that the Mediterranean diet looks to be heart healthy, but a few years ago, we kind of got the definitive evidence. Next slide. So this is the PREDIMED study. If you look at all the diet studies, one of the problems in the diet world is everything's what we call an observational study. You ask people what they eat and find out what happened to them, and then say that's a good or bad dietary pattern. And the problem there is what people choose to eat keeps a lot of company. So they may choose a certain diet, but they may have different sleep patterns or exercise patterns or weight. So that keeps a lot of company. The best study is what's called a randomized trial, where you flip a coin and half the group does one thing and half the group does another. And that's what they did here in the PREDIMED study, that the best evidence we have for reducing heart disease in a nutrition study. So here what they did is they took 7,000 people, and half of them had their usual diet, controlled diet, and the other half, they put them on a Mediterranean-style diet. And what you see over time, those curves start to separate. By the way, the Mediterranean had two arms in it. One was a Mediterranean diet where they had more nuts, which was 30 grams a week of walnuts, hazelnuts, and almonds. And the other Mediterranean diet was one where they did extra virgin olive oil. They gave them 1 liter a week to use liberally. Doesn't mean they drank a liter of olive oil a week, but they told them to use it liberally. The bottom line is it was a 30% reduction in cardiovascular disease events. The only dietary randomized trial we have showing a reduction in cardiovascular disease events is Mediterranean diet. So that's the pattern that we generally advocate for in our patients. And concomitant with that is making sure we're lowering saturated fat if we're trying to lower cholesterol. Next slide. So that's the dietary part of it. And I want to pivot a little bit and talk about the new cholesterol guidelines that just came out in November. So it's very timely. And the chair is Scott Grundy, who's here, my colleague here at UT Southwestern. Next slide. Now, we're going to talk about medicines a lot, but I want to remind you the number one, they had top 10 take-home of these guidelines. The number one take-home was in all individuals emphasize a heart-healthy lifestyle across the life course. So it's never, I always tell my patients, it's not medicines or diet, it's both. And for some people, it's just diet. If you've had heart disease or heart attacks, it ends up being both. But healthy lifestyle is critical. So even though I talk about medicines, I don't want to forget that. Next slide. The number two thing, which is what we'll talk about, and I'm focused on patients who, or people on this call who have already had ASCVD, atherosclerotic cardiovascular disease, a heart attack or a stroke. And in those patients, the guidelines say, as well as in 2013, the guidelines said the same thing, that if you've had a heart attack or stroke, you should be on a high-intensity statin. And let's talk for a second what a high-intensity statin means, or why, why are we focused on statins? Next slide. So I bet you in the question and answer, we're going to hear a lot about statins. I usually do get a lot of questions because there's certainly a lot of side effects, and it's worth talking about those. But for this, I want to tell you why is it that statins are a first-line drug. And the answer is they've been studied more than almost any drug in cardiovascular medicine that we know of. So this is what we call a meta-analysis, pulling together data. And here, 170,000 people have been studied, more than almost any drug that anybody takes. So at least we know consistently. In the orange there, anything on the left of that white line down the middle says benefit. Statins we know compared to placebo lowers non-fatal heart attacks, coronary death, stroke, major vascular events. So pretty consistently they work and they lower events. Next slide. So what's a high-intensity statin? Sorry, these boxes didn't transfer in the slide set. But on the left, if you have had a heart attack or stroke, in general, that's the medicine and doses you should be on based on trials, and I'll give you one in just a second. So that's atorvastatin or Lipitor, 40 milligrams or 80 milligrams, or rosuvastatin, which is Crestor, 20 or 40 milligrams. That's what the guidelines say. If you've had a heart attack or stroke, you should be on the highest dose of these drugs. Now, of course, if you have side effects or issues, sometimes you're on lower doses, so that's okay if there's some problems. But generally speaking, most should be on those drugs and those doses. Next slide. And the reason that we say that is because of studies like this. Here's one example, but there's 5 studies like this, and they all show the same thing. Here they took 10,000 patients that had stable coronary disease. They'd had a heart attack or a stent in the past, and half of them in yellow got 10 milligrams of atorvastatin or Lipitor, a very common dose that people use. And they said, well, 10 milligrams is pretty good, but what if we give the other half a high dose, high intensity statin, 80 milligrams of atorvastatin? They saw they got a further 22% reduction in events. And the LDL, the bad cholesterol, came down from 100 to about 77 or so. So on top of being on a statin, being on the higher dose in these higher risk patients further reduce risk. And that's why it's recommended, not just from this trial, but about 4 others. Next slide. So what happened is in the past, we used to say, well, if you've had a heart attack or stroke, get on a statin, and that's great. And most people are on statins, hopefully high intensity statins. But what's happened since the prior guidelines in 2013 is we've had some new drugs come out and new evidence regarding these drugs. And I'll talk about 2 and tell you what the guidelines say about them. So the first is a drug that some people may be on called Ezetimibe. What Ezetimibe does, and here this is a drawing, it's a pill, by the way, it's once a day, where that's a drawing of the intestine. So when you swallow your food and it goes down in your intestine, the yellow is dietary cholesterol. There's cholesterol in our diet that we're eating, and our intestines absorb that cholesterol that goes back to the liver, and that's how you increase your cholesterol in your blood. Well, Ezetimibe, essentially what it does, it blocks it's a cholesterol absorption inhibitor. It blocks your body from absorbing cholesterol, and it lowers your cholesterol. So that's the good news, and it's easy to take once a day. But the downside, I guess, is not very strong. It lowers your LDL by about 15 to 20%. Not bad, but not nearly as strong as statins or another drug we'll talk about in a minute. So definitely an option that people can take if their cholesterol is still high after being on a statin. Next slide. So the newer drugs available now are called PCSK9 inhibitors. And this slide's a little confusing, but I'm going to walk you through it just so you understand how they work. So on the left is what our bodies are doing all the time. The purple things there are called LDL receptors. So essentially those bind the LDL, those green with the dots. They bind the LDL in our blood and pull that into our liver, and that thereby lowering the LDL in our blood. So essentially your liver is pulling the cholesterol, the LDL cholesterol out of your blood and bringing it into the liver, so lowering the LDL in your blood. So those receptors are really critical there in terms of pulling it into the liver. So on the right, we have this enzyme called PCSK9. We all have it. And this PCSK9, it binds to those receptors, those purple receptors, and it causes those receptors to break down. The liver takes in those receptors and breaks them down. So then you have fewer receptors. So the more PCSK9 you have, the fewer of those receptors you have, and the less LDL you're pulling in your liver. Said another way, the more PCSK9 you have, the higher the LDL in your blood. Well, based on a lot of genetic models, which show that this is possibly something to target, they've developed these PCSK9 inhibitors. These are injections, they're antibodies, and they essentially bind to that PCSK9 so that those PCSK9 leaves those receptors alone so they can continue to pull the cholesterol into your liver. Next slide. So now there's two PCSK9 inhibitors available, FDA approved. One's called Evolocumab on the left, one's called Alirocumab on the right. They're both pretty effective. And when I say effective, they lower your LDL by 50 to 60%. That's on top of a statin. So very potent and can be a good choice for some patients. You see those pens are essentially injector pens, pretty easy to use. And you give yourself a shot every 2 weeks, can be given even once a month. Next slide. Here's one recent trial called Fourier, where they took about 26,000 patients who had heart disease, and they randomized them to continue on their statin alone or statin plus this PCSK9 Evolocumab. What I wanted to show you here is what happens to people's LDL, the bad cholesterol. So in the statin alone group, the LDL was at 92, which is not bad, but not perfect. But when they added the PCSK9, it went down to 30, which is way lower than most of us are used to seeing, although we're seeing a lot more patients with those low levels now, and they were 30 for about 2 years. This is my last slide. Next slide, please. So putting it all together, and I'm sorry again that this box got messed up, but essentially this is what the guidelines say. If you've had clinical atherosclerotic cardiovascular disease, if you look to the right, if you're very high risk, meaning if you've had a recent heart attack or multiple recurrent heart attacks or strokes, you've had one, but also you're older and have diabetes or are currently smoking. So if you're higher risk, everyone should be on high intensity statin. And then if your LDL is still above 70, and that's being blocked by that box there, and I apologize, but it says if your LDL is still above 70 on a statin, you can consider adding Ezetimibe next. It's a very reasonable thing to do. And if your LDL is still above 70, even though you're on the statin and Ezetimibe, you may consider that PCSK9 inhibitor, the last slide that I showed you. So the bottom line is most patients, we talked about diet, incredibly important. We talked about lowering saturated fat, what is considered a heart-healthy diet, and looking at the pattern like the Mediterranean and not playing whack-a-mole with one nutrient or the other. And then we talked about drugs that everyone with atherosclerotic cardiovascular should be on a high-intensity statin. And now the guidelines say beyond that, two other things that can be considered are Ezetimibe and PCSK9 if your cholesterol is still high. Okay, I think that's my part, and I'll pause and let our other speakers take over.
Thank you very much. I appreciate that. Lots of great information. We will now hear from a patient and a caregiver on some practical tips from the patient and caregiver perspective on controlling your cholesterol through diet. And I will turn over the microphone to Ron or Angela. I'm not sure which one of you would like to do these slides.
Thank you, Andrea. Being a heart attack patient, I have always had a family history of heart disease. My father died of a stroke, and my mother died of a heart attack. So I've always had that in my history, although I always thought that it wouldn't happen to me. So in 2004, I had a major heart attack. It was quite a shocking situation. The other piece I'd like to add into there is you fall into a depression, which sometimes comes with a major heart attack, and sometimes you have to work your way out of that. But having a heart attack, you kind of feel that, where do I go next? You feel terrible. You're trying to move ahead. You're trying to move ahead to a healthy lifestyle, and feeling terrible is the main thing. And the other thing is, if you want to not have a second heart attack, that always is the danger of happening after having the first heart attack. So I had to manage my high cholesterol and, of course, high blood pressure, and I started taking a series of meds, which I've been taking for all this period of time. I went back and looked at my history, and I had to write down some of the things. But basically, during my working career, I ate often at fast foods with high saturated fat, and most of the foods, they put lard in the foods to make it taste better. And also, my afternoon snack was always from the vending machines and high soda intake to give me that afternoon boost after lunch, which I knew wasn't doing good to my health, but you know, I didn't have a heart attack, so I just kept on going. And of course, try to manage my stress, which is almost impossible in a working environment. So I had to reduce my saturated fats and calorie intakes. I started reading more and more of what I needed to do. So I switched over to a vegetarian diet, and which adds more fruits and vegetables and virtually eliminated red meat from my diet. And the only thing I have now is fish, which the new thing is to have omega-3s in your diet. So add in more fish at least once or twice a week now, and more fruits and vegetables. I do like legumes. I eat a lot of beans, and that's usually in my diet about 3 times a week, which I think is important when I'm reading and following. In addition to the statins, I just was prescribed a new drug by my doctor called Vasepa, which my understanding is a fish oil, and it's just a new drug I've been taking. So the results, I have to find out what the results of that would be as the time goes on. I'm exercising daily now. I go to the gym daily, and I do cardio and light weights. I still have a good golf game, so I want to keep my muscle together and for the swing that I use. And of course, cardio, I use the treadmill and go on that frequently. And I feel that at the end of that, I feel better. I know that saturated fat is not good. I recently had a trip to New Orleans where I ate a lot of saturated fat, and I could tell right away that I was beginning to slow down. And I was quite concerned about that, but I don't eat that kind of diet normally, so I'm going to move on from that. And also, one thing in talking to folks is that they don't check their blood pressure and cholesterol levels. Is they think they're immune since they're not sick. But, you know, it's almost like an accident waiting to happen as I talk to folks in my age group, that you need to check those levels often, your cholesterol levels often, because that's going to happen as the time goes on, just by a particular age. And A1C, which is a diabetic, I know it wasn't mentioned here, but now considered borderline diabetes, and I need to watch that as that is a new thing that's cropping up in my blood pressure and my cholesterol situation, and the blood test for A1C. That's important. And I also would have to say is that don't avoid your primary care physician or your cardiologist. It's something you need to meet with them regularly, stay on the schedule, and always take your medication. Sometimes when you feel better, you feel okay. I'm talking to a lot of folks and patients that they skip their medications and don't take them. So the combo, which is good diet, medication, and exercise is the 3 I'd have to say, and continue with a low fat. We've switched over using, Angela will talk about that in a minute, how she prepares those foods. And that's it for me.
Thank you, Ron. Angela, we'd love to hear from you.
All right, thank you. And if you can move that next slide for me, please. And after Ron had his major heart attack, I always say that Mended Hearts found us. And it was actually attending Mended Hearts meetings that I learned that high cholesterol was such a high risk factor for heart disease. When Ron had his angioplasty procedure that saved his life, I became his primary caregiver. So I had to learn how to cook low-fat meals, low-cholesterol meals. And when Ron got better, I started to transition the responsibilities of embracing a heart-healthy lifestyle between us, because he was very appreciative of the changes I had made to help him feel better. And of course, I appreciated that he was a good patient. So we make decisions now that help Ron and me stay well and still manage our cholesterol and heart disease. If you are a caregiver for yourself, I do encourage you to seek out the closest Mended Hearts chapter for peer-to-peer support. I believe we all need caregivers, and it makes a difference because we learn, understand, and support each other, and share your best practices of managing your cholesterol with each other. Now, Ron's heart attack was a major life-changing event for us, and we attended a marriage encounter weekend. And it taught us to be open, that feelings are not right or wrong, and we learned tips on how to dialogue with each other. We still have talks on maintaining our healthy lifestyle. I learned that through dialoguing how difficult it was for Ron to embrace the new diet and give up the foods he liked, but we understood they were killing him. We're always working on what is best for us, and there is a lot of give and take. Ron will always need to manage his cholesterol. Ron must take his medication, must eat healthy, and exercise. I'm not a morning person, so Ron takes the lead in the morning to make a low-fat breakfast. I take responsibility for other meals. I have made modifications in our diet to support him, such as cooking with olive oil. I use egg whites. We eat multigrain breads, Quaker oats, and we eat brown rice, along with other healthy meals. Since I take responsibility for preparing the meals, I also consider ways of cooking more healthier. And so right now I am cooking with the air fryer. And it is cooking without oil, which reduces calorie intake and fat. And it, of course, significantly helps us to manage cholesterol. I do have fruit on the kitchen counter, and we add vegetables to our meals. We are proactive when we go out to eat. We choose meals like fish. When we travel, we, for example, might buy a Subway sandwich instead of a high cholesterol fast food, because it avoids us getting overly hungry, and then we're apt to eating everything. So for me, I must be organized so we don't default to our old ways. It is planning our meals, scheduling our exercise classes, and adding medication reminders into our daily routine. I have an ongoing grocery list that I keep on my refrigerator. I periodically take pictures of it, so if I'm out and I want to stop at the grocery store, I buy only what I need, and it supports our low cholesterol, low fat diet. This helps me to avoid buying processed high sugar and high fat foods. I even add snacks to our grocery list, and almonds is one of our favorites. Yes, we sometimes skip our workouts and we eat comfort food, but we don't give up, and we hit the reset button. We remain focused and organized because we want to feel good and be healthy. My suggestion is make a plan that works for you. It will help minimize your stress and frustration. And there is a song I like, "Don't worry, be happy." Worrying causes stress, and it may even raise your cholesterol. It has a negative effect on our bodies. I start my day by being grateful for all that is good in my life, and when I am happy and I am positive, happiness is contagious and it is good for our health. And whenever you can, relax and laugh and make things fun. Good fun is another way of healing for both the patient and caregiver. And those are Angela's caregiving tips for today. Thank you.
Thank you so very much. We will now take some questions, but beforehand, I would like to take a moment and thank the American Society of Preventive Cardiology for their partnership on this educational webinar series. And I would also like to thank Amgen for their educational grant that they were able to provide us so that we can bring these wonderful webinars to everybody. I will now take some questions, and I have a question here. The first one is, it says, please ask Angela and Ron if they think the air fryer makes food that tastes the same as fried food. Also, what foods do you fry?
Well, I think the air fryer, the food tastes better, and Ron is a vegetarian, so I use the air fryer for fish, but I'm not a vegetarian, so I do like chicken. So that's probably one of my favorite foods is air frying chicken.
Great, great. I will just remind everybody that you can type a question in the chat box. It should be on your right-hand side of your screen. You can also raise your hand if you have questions, and there should be a little hand that's beside your name, and you can press that and it will alert me that you have a question and you would like to be unmuted if you would like to speak your question versus typing it within the chat box. I will give everybody just a moment. I did have a comment. It says, thanks to all of the great speakers. This was a great webinar, and I have to agree. So thank you all for presenting what you did.
Andrea, this is Dr. Khera. Can I ask a question to Ron and Angela?
Yeah, absolutely.
Yeah, well, thank you both, by the way. I one of my favorite things is to hear people's stories because everyone has a different journey. Obviously, everyone is affected, and how people approach that is unique. Everybody's in a different situation. So, your approach to making, first of all, congratulations on embracing your health and making these changes. Something Ron said, which I want to repeat, is about 40% of people after having a heart attack have clinical depression, especially younger people, and so it takes a while to get out of that. And I'm glad you've chosen to embrace your health. My question for you is a little bit about some of the nuts and bolts. Now, Ron, you said you switched over to more of a vegetarian diet with some more beans and some fish. That's frankly so different than what many of us grow up eating in our Western diet. How did you? What are some of the things you did? Was it cold turkey? Did you gradually move towards that, or how did you do that?
A little story that I had when I was in the hospital. I knew that I was on the wrong track. So the first thing they gave me, they didn't value a good diet. They gave me beef on the first day. And one thing in the hospital you'll find right away is they don't like it when you don't eat. So I stopped eating.
Yep.
And I told them, until you bring me a nutritionist up to my room, I'm not going to eat. Well, it created a reaction. Nutritionist came to my room and I said, I will not have any more meat. I'm switching to a vegetarian diet. Please switch my diet. And it started there. It was cold turkey. As time went on, more and more has been written about omega-3s. So I switched and added fish to my diet. So that was one of the things. It was a cold turkey. It is hard. When I go by meat places and smell the beef coming through, it is hard. And I can smell it 50 feet away. Even from the street, I can smell it. So that doesn't ever go away. But yes, I did do a cold turkey.
Thanks for that. That's really helpful. And I know you're not advocating hunger strikes for everybody, but it seemed to work for you. So that's good.
Great. All right. We've got lots of questions coming in. The next question I have is the person has normal cholesterol levels, nothing of concern to my doctor, 69 years old, and he likes milk. Is full fat 2% or skim milk? Which is the best?
Maybe I'll take that first and see if our other speakers want to comment. The first is, if someone does not have heart disease at all and their cholesterol is excellent and there's no strong family history, I think one thing which was key in Ron's presentation was he had a strong family history. And I think that's so important for people to be aware of. But if someone really has no cholesterol problems or no family history, then we're not, of course, we think everyone should eat a heart healthier diet, but we're maybe not quite as stringent because the risks are lower and so forth. So in my personal opinion, I think skim milk is perfectly fine for everybody. I appreciate why many people aren't used to that, and it takes a while to get used to it. If you look, really, I'll give you an example in terms of one's necessity and the other's taste. Kids can switch off whole fat milk after the age of 2, because then your brain is formed, all the things that you need that fat for has been in place. So we don't really need it. That's a biologic point. The taste, I understand, is different. If someone has high cholesterol, I definitely would move towards the skim. If your cholesterol is good and you don't have heart disease or a strong family history, then you might be able to liberalize that a little bit.
Great answer. Thank you. The next question is maybe for you as well. It says, are some vegetables bad, such as the sweet potatoes?
Yeah, good question. And I appreciate the fine tuning there. Here's my 10,000-foot view on that. At least generally speaking, most of our Western diet is so far away from eating enough fruits and vegetables that I worry a little less about eating the bad ones. Having said that, though, we do think about things that have high glycemic index, like white potatoes, things like that. Generally speaking, broad brushstrokes here are a lot of green leafy vegetables is good. We talk about eating the colors of the rainbow, so eating a variety of all of them. And really, one other term which is used, and I know Ron used the word vegetarian. I think that certainly is a great term. And what people pivot is what we call a full food plant-based diet, because that involves really focusing on plants and whole food, meaning you could process vegetables up enough where you'll never recognize what they are again, and all the nutrients are out of them. So the goal is to try to eat them in their natural state as much as possible. But generally speaking, I'd say other than people with blood sugar issues, where potatoes and things might raise their blood sugar a bit more, I don't think of any specific ones that are of concern.
Great.
With one caveat, sorry, I should always say, obviously people on certain blood thinners like Coumadin have to be careful with too much green leafy vegetables. It can change the levels.
Wonderful. Thank you. And I am not sure, maybe Angela, maybe you would be a great person to answer this question. But the question is, my kids are not a big fan of the Mediterranean diet. Are there any kid-friendly things parents can do to change a few things to make our diets more healthy?
Well, that's a good question. I have grandchildren, and it is a challenge for me as a grandmother. I try to, when I make macaroni, I try to introduce vegetables by cutting them up very small. Some of them eat it, some of them still pick them all out. I think that what I would do, and I'm still trying, is I look for a healthy diet for my grandchildren, and then I just experiment. And that's what you do. You introduce something that they do like. For example, they may like a hamburger, so then I would add to the side maybe a fruit. You could put a little bit of whipped cream on it. Vegetables, but maybe make it a little bit more interesting, add some almonds to it. I would just not give up and continue to experiment and introduce different foods and journal and see what they like, and then just keep moving forward on that. I hope that helps.
Great, thank you. I think experimenting is a wonderful thing. So the next question I think would be for the doctor. It says there was no discussion of weight. What does the cardiologist say about recommended weight in terms of BMI or percentage of body fat?
Yeah, thanks for asking that. That's an important question. It's a little bit of a tricky question, and I'm going to confuse you before I answer that. There's a funny thing, and we call it we call it obesity paradox. And here's I will confuse you, but I'm going to do it anyway. And there's a lot of information that if you've had a heart attack or stroke, believe it or not, if you map out people's weight and who lives the longest, or it turns out that once you've had a heart attack or stroke, being slightly overweight actually is protective in an odd way. Being significantly overweight is another story, but I mean relative to normal weight people, and that's confusing. I tell you that only because if you read it, if you Google that obesity paradox, you'll see that, and it's not completely clear why that is. Whether it is that when people are normal weight or underweight, have other diseases that affect them, so that's why they end up being underweight or overweight. But the short answer is normal BMI is under 25. That's what we generally aim for. My focus on weight, so here's what I do. I of course pay attention to everyone's weight. When they're obese above 30, we certainly pay attention to that and talk about the importance of weight loss. But the time that I'm focused most is people that have metabolic problems. For example, if people have prediabetes or diabetes, weight loss makes a huge difference. So when I see people that are blood sugar a little higher, right there on the fence of diabetes, I can tell you how many people their A1C or blood sugar really plummets by significant weight loss. The other people are people who have high blood pressure or blood pressure issues. So blood pressure and blood sugar are going to track with weight very closely. If your blood sugar and blood pressure are good and your weight's just a little bit high, I think it's important, but I don't make that my number one in terms of priorities that we focus on that day. So really, I'd say BMI under 25 is normal. My focus is kind of proportional to what's your blood sugar and what are your blood pressure and triglycerides also, your metabolic parameters. If they're out of whack, we focus even more on the weight.
Wonderful, thank you. And this next question is also for you. It says, could you speak to the side effects of cholesterol medications? Are there things to watch for and how to work through them? And maybe Ron might have an answer to that as well.
Yeah, I'm glad. I certainly want to hear Ron's perspective as well. And I'm glad you brought that up because I didn't go through the side effects, and I'd be remiss not to. I just knew it would come up in the questions. It always does. Statins, I'll start with statins because those are the most common drugs and the ones we should start with. And there definitely are side effects. And the way I describe it to patients, if you think, most people are on, 4, 5, 6, 7, 8, 9 medicines, most of those medicines have been studied somewhat, but not that much. And so in some way, ignorance is bliss, where we don't know all the side effects yet. So I think they're fine. The statins, the good news and bad news is the good news, they've been studied in so many people, we know that they work. The bad news is we know every side effect. And those are well aware. Anybody can do a quick Google search and you'll see those. Now, let me walk you through the most important ones. The most common one is muscle aches. So 1 in 10 people get muscle aches from statins. But I'd like to remind my patients that means 9 in 10 will not get them. And if you do get them, you stop the statin, it goes away. So that's important. If you have muscle aches, then work with your doctor, because often if you change drugs to a different one, especially starting at a lower dose, often that can help and alleviate the symptoms. If that doesn't work, there's a lot of tricks we do. I see this a lot. This is a very common referral I get. So there's many tricks to helping with that. Other side effects I'll just mention briefly. Your liver function tests on a blood test can go up in about 2% of people. But if you look at the FDA in 2012 told us we do not need to routinely monitor liver function tests because statins so rarely cause liver problems. So we don't focus that much anymore. And they can mildly increase your blood sugar. So if you already have pre-diabetes, it'll raise your blood sugar by a few points. But even in those people, it still lowers heart attacks and strokes by a third or more. So way offsets that few point increase in blood sugar.
Great. Thank you so much. The next question is, Ron, I'm sorry. Did you want to add anything? Did you have any side effects from your statins?
I want to say yes. And I have to say, as heart disease patients, you want your life to be perfect, and it's not. But the best thing we can do is what the doctor said is you go back to your doctor and change the medication. I have a little bit of a leg cramp at night, but sometimes I'll just push my leg out and move it, and then it goes away. So sometimes that happens, but the results of the medication work. It brings you back into the normal ranges, and those are the things you need to consider. But you could always change your medication. And then also, the lifestyle that I lead is you keep busy. Try to not concentrate so much on your aches and pains. I know that after New Orleans, I was having a little bit of chest pain, but I was chomping down the donuts and the fritters. So it's always need to maintain a good lifestyle, and you're going to have some side effects. It would be not true to say that you don't.
Great, thank you. The next question is, does portion size matter on healthy foods?
I guess we both can take that, really. I mean, yes and no. Remember, so there's two parts to that. One is the quality or the nutrient content, and the other is the total calories. So if you had huge portions, if I ate, a room full of fruits and vegetables and ate pounds and pounds of it, I will gain weight. So it does matter in the sense of weight gain if there's a huge amount of calories. I will tell you, for most people that are eating sensibly and move towards a Mediterranean pattern, and really, my nutritionist tells everybody, if you fill half your plate with fruits and vegetables, very little room for the other stuff, and fruits and vegetables don't end up being calorie dense. So it ends up being pretty hard to eat too many calories if you're eating a lot of fruits and vegetables, but it's possible. So the short answer is it does matter in the sense of weight gain, but I still, pound for pound or plate for plate, you're getting a lot fewer calories than our kind of traditional Western diet.
Great. So we have just a couple more questions, and I appreciate the audience's response to all of the questions. I am going to get through as many as we can before the 1 o'clock hour. If we do not get your question in, you can feel free to email me, and I will give you my email, and I will get the answers to you from the panelists via email. But the next question is for the doctor, and it's a little specific, so I will just read it. It says, following valve replacement surgery, I was put on statins. My previous cholesterol was 256 with an HDL of 79. My pre-surgical angiogram showed that I was clean as a whistle, no deposits. And I was told that the statin would prevent future problems. So I spent months changing my diet to lower my cholesterol. When it was tested, there was no change. My doctor said that I had genetically high cholesterol and that diet wouldn't change it, only statins. They brought down my LDL, but also my HDL. So I worry that the statins has worsened the situation. I eat a healthy diet and wonder if this is a common situation and what is the best way to manage that situation.
Yeah, thanks. You are right. That is a very specific situation, which I appreciate the question. And, you know, since I do preventive cardiology, I see that scenario not infrequently, believe it or not, a tough one where you don't really have buildup problems in your arteries, but you have genetically high cholesterol. So the first thing is that genetically, I would want to know in any patient, it's really important to know about genetically high cholesterol. Well, how do you know that? One is, I always get patients to get me their cholesterol levels of the family members if they can or if they know anything about it. So if it's really high in your family, it's going to be pretty hard to get it down by diet alone. It's not your fault. It's just you're fighting your genes there. If you know, it's always worth. The one thing about prevention, I always say it's almost never an emergency. So I can always give it a try where we try important dietary changes and being pretty rigorous about reducing saturated fat and cholesterol. And if you do that and your cholesterol is not coming down, well, then it's kind of what we call shared decision making, talking it through with your doctor about the pros and cons of being on medicine. Again, this patient that we're talking about here, the person that sent the question, has never had a heart attack per se. I understand the valve issue, which is a little bit different, and the arteries didn't have any buildup. So it's kind of a personalized decision about whether or not to be on cholesterol medicine. The answer is probably should if there's genetic cholesterol. And then, but that patient, if you're having side effects, you can really work with your doctor about doses and types and different things, help avoid those side effects. Because again, you don't need the big guns of medicines and drugs because you haven't had a heart attack and you're not trying to achieve very, very low numbers as we've tried in others with, as I showed you in the slideshow. So take-home points are, if you truly have a genetic cholesterol disorder because you know everybody has it, you've tried with diet and it's not coming down, it's worth weighing the pros and cons. But medicine's often considered, and then there are various options to that.
Great, thank you. This question is for Ron. It states that you mentioned that your diet wasn't as good as it could have been on a recent trip you took, and you immediately felt the negative effects on you. What is your advice for eating healthy while on the road?
Well, I have to say that the South isn't the best place to get a healthy diet. So you have to probably talk to the preparers and see what foods are available on the vegetarian side. Of course, you want to eliminate red meat if you can, oysters, and they had these weird-looking thing called crawfish. You want to eliminate those. So those were bad things. So you have to try to work with the cook and work with the attendant there to see if you can help. But I would stick to fruits and vegetables that were available. I'd ask for them and just kind of take a stand. They look at you a little weird, but who cares? You have to just move forward because it's your health that matters, and try to stay away from the high fried foods.
Great, thank you. So this question is for the doctor. It states that, could you speak to cholesterol versus obesity as a risk factor? Is the issue what we eat or how much we eat, and whether we gain on the pounds? And I think we kind of talked about that a little earlier, but is a burger every now and then okay, or is that just not, should you cut it completely out?
Yeah, great question about kind of digging deeper in cholesterol versus obesity specifically for heart attacks and strokes. I'll answer that as an epidemiologist. I do research as well, and cholesterol epidemiologically is a bigger risk factor. Weight is important, but weight has a lag. Weight does it via other mechanisms. For example, when you gain weight, yeah, it has some part effects, but it also does things indirectly, meaning it raises your it raises your blood pressure and leads to diabetes. So usually we see a lag time when, people have gained weight, then a few years later or several years later, they develop diabetes, and then diabetes is a markedly increased risk for heart disease. So I guess what I'd say is weight is important, but it's multiple kind of steps in between as to how it leads to heart disease, and cholesterol ends up being a bigger risk factor, although both are important. And then the second was about burgers and things. Listen, people have to live. So I don't think the goal, in my opinion, is to lead a life, a joyless life, whatever that means to you. But I do think what happens, and I think Ram was a great example, and I can speak for myself as well. I grew up eating different types of foods. When you change what is normal for you, your average, your daily staple of what you usually eat, if it's more plant-based, legumes, fish, you get used to that, and actually you can make delicious food. So if you occasionally want a burger, that's fine, certainly, but it's what you're eating most of the time is the big question.
Wonderful, thank you. So I think we have time for just one more question. I do know there are a few in the queue, and I want to thank you all for such amazing questions and the great conversation. I am going to unmute Rosemary King. You have your hand raised, and I want to do the final question to unmute you and let you answer your question or ask your question. The rest of the questions, I will reach out to you via email if you would like. My email address is Andrea, ANDREA .Baer, BAER, at mendedhearts.org, and I will get you the answers to your questions. Rosemary, you should be unmuted.
Oh, okay. Thanks, Andrea. My question, I think, might be for the doctor. I'm on atorvastatin, and I get terrible nocturnal leg cramps. I was on 10 milligrams. My LDL went up, and so she increased it to 20. I usually take about 15 to control the leg cramps. But I just wondered, and I tried, someone suggested taking CoQ10. So I'm taking 200 milligrams a day. I noticed that's not recommended in the guidelines. I just wondered if you have any tips on what I can do to control the leg cramps. Hello?
Yeah, I am here. Did we lose the doctor?
Can you hear me?
Maybe.
Sorry.
Oh, now we can hear you.
Hello? Sorry about that. I was on mute briefly. The goal here, and I think it's so important that I say this. I know I talk a lot about cholesterol medicines. On purpose, I did diet first because I want people to, our goal here is not to have people have poor quality of life. And if you're having a lot of side effects from medicine, the answer is not to just suck it up. That's not it, because, quality of life is important. I'm a little careful about giving specific medical advice, obviously, for lots of reasons, since I've never met you on a personally, but I can say that, a couple of tricks and different things that people do. So first is, again, trying different doses. Second is, frankly, 10 to 20 milligrams of atorvastatin is only 6% difference in your LDL cholesterol. So if it was 100, it would be 94, which is not a huge difference. So if your quality of life is impaired, it's worth discussing whether that's worth it. The other thing is sometimes there's other drugs we can add on. So some people use low-dose atorvastatin, add that Ezetimibe drug that I mentioned. Again, without telling you what to do, I'm just telling you different options medically. We call it a booster, if you will, because then you don't have the side effects as much if you're having them with the statin. And then you mentioned CoQ10. There have been about 5 trials that have looked at this. 3 have said CoQ10 helps with muscle aches. 2 have not, so the guidelines don't recommend it. My personal opinion, though, is, some patients I've seen have taken CoQ10 and they get less muscle aches. I'd only take it if you got muscle aches, but it helped them. Now, I don't know if it was the drug or whether it was the placebo effect, but to me, it doesn't matter. They felt better, and that's the important thing. So I think there's lots of strategies, but the first is the goal is not to have a poor quality of life, and working with your doctor about the need for changing your medicines and how to do that.
Thank you.
Wonderful. Thank you. Well, that concludes our presentation today for controlling your cholesterol with diet modifications. I would like to thank Dr. Khera, Ron Manriquez and Angela Manriquez for being our panelists today, and I hope that everyone learned a lot. You can join us next month for our next session in this risk reduction series. Thank you and have a great day.
Thanks so much. Appreciate it.
Thank you so much.
Thank you.